Hello, and welcome to Let's Talk SADS Live, Canada. I'm your host, Dr. Shubayan Sanitani, and I'm coming to you from Vancouver, Canada, where we're having a beautiful spring morning. Hard to believe it's the middle of April already. And, as usual, we are coming together in this space and learning together about SADS conditions, sudden arrhythmia death syndromes, SADS conditions that affect so many of our viewers and our members. Sudden arrhythmia death syndromes can strike at any time, and many of our families have been impacted, and the diagnosis has come to light through often tragic events. And so we come here together to learn, and really with the goal of improving the care of SADS families and the patient journey. And so I'm very privileged to come to you from Vancouver, where we are going to talk today about one of the SADS conditions. And, we had some technical issues, but I hope you're seeing my slides now. And I'm going to advance my slide. Evan Kruger, of course, is my technical wizard here. And we are set. There we go. So visit our updated information section. So we've been really working as we've slowly emerged from, or are emerging from the pandemic, really on a reboot for the Canadian SADS Foundation. And we're very grateful to Pam Husband, our executive director, whose tireless energy has re-energized the SADS program, and our great support from our neighbors to the south with Alice Lara and Aaron and Mike Ackerman, of course, and Susan Estridge and many others who are helping us in the Canadian SADS Foundation. So check out our website, send us some feedback. We're always trying to make it better for you to get your information. So last year we did, historic Canadian facts, mostly medical history. This year I'm trying to teach us some interesting things about fun facts about SADS conditions. Of course, my idea of a fun fact and everybody else's are not always aligned. We talked a little bit about CPVT and arrhythmogenic cardiomyopathy. And here's, in the original report by the Brugada brothers, 3 of the 8 patients were children under 10, and that's going to come back. So these are past ones. Arrhythmogenic dysplasia became a cardiomyopathy in 1995, so almost 30 years ago. Is that possible? Wow. Today's Did You Know is, did you know that the first ECG of a child with long QT syndrome was actually recorded about 100 years after the original description? So the original description was in the 19th century, the mid-19th century, 1856 in Germany, about a very severe case with deafness and sudden death, which we now know to be Jervell-Lang-Nielsen, the severe form of long QT syndrome. But it wasn't until 100 years later, when we had an electrocardiogram, that we could then record what was originally described as these bizarre ECGs. And so really the early days were all about figuring out why these events happen. Now, people might wonder, why am I telling you about long QT when we're actually not going to talk about long QT today? But that's another story. So I'm really excited today to be bringing a guest that I've had the privilege of knowing for the last several years. Dr. Elijah Behr is a professor of cardiovascular medicine at St. George's in London. He's the director of the Cardiovascular and Genomics Research Institute, as well as a consultant at St. George's University and the NHS Foundation and the Mayo Clinic Healthcare. I did not know Mayo Clinic had a branch in the UK, so I'm learning every day. He also is the past president of the Association for Inherited Cardiac Conditions and the first chairperson of the European Cardiac Arrhythmia Genetics Group of the European Heart Association. So lots and lots of accolades. I remember meeting Dr. Behr at a heart rhythm meeting, and he had very aspirational ideas about getting international collaboration on genetic research, and he's really made an incredible mark on this. He's also written a lot about Brugada syndrome, including a paper that just came out in my Twitter feed. I guess we don't call it Twitter, we call it X, just this past week. So we're going to ask him lots. So please bring Dr. Elijah Behr into the studio, and I'm going to look forward to learning as much from him as all of us are. So, Dr. Behr, and I will apologize, I may slip into an Elijah now and then. Thank you so much for joining us.
Thank you, Shoe. I'm going to slip into the shoe.
That's okay, if the shoe fits. Yes. Fantastic. And thank you also. It's about 5 o'clock there, so Dr. Behr is waiting for his tea time to do this. So I always like our viewers, and many of them will watch this later in the day and tune in at their own time. I always like them to understand a little bit about our guest's journey. So how did you even end up in this very niche field? Because the training in the UK is also quite different. I think one does a lot of years as an internal medicine person and stuff. So just take us a bit how you got hooked onto inherited arrhythmia.
Yeah, well, I suppose it depends on how far you want me to go back. But I, as a trainee in cardiology, and here, as you said, the system is very structured, or it was undergoing a restructuring at the time. But I had an interview for the I suppose you'd call it the residency position, registrar of residency. I think that's the right sort of level.
Yeah, sort of after medical school, before becoming a consultant.
Yeah. So we already had a pre-residency program. Our internship lasts about 4 or 5 years, and then you go to the residency, which lasts about another 5 or 6 years. So they really dragged it out for us at the time. But I was doing my interviews for that, and that was successful. But somebody in the interview panel with a chap called Professor Bill McKenna, and some of you might know him because he's Canadian originally, and he was a forerunner and an early adopter of genetics and cardiology, and was a mentor to many around the world, but particularly in the UK, of cardiac genetics, particularly in the area of cardiomyopathy. But he called me up and said, Elijah, I remember you from your interviews, and I wonder if you're interested in the idea of doing some research into something called sudden arrhythmic death syndrome. And then he explained to me about normal hearts, normal heart sudden death, where there is an unexpected and unexplained sudden death. Explained to me that he thought there was a genetic background to it, and that he wanted to do genetic research around it, and was in the middle of a program where they needed a fellow to take hold of it and take that forward. And that was in 1997. And so then I started working for him a year later, and never looked back, really. He was always a very motivational character, an inspiring character. And I then also had the opportunity to work with John Cam. Professor John Cam is a very famous British electrophysiologist and cardiologist, who I also learned a lot from with regard to arrhythmias and sudden death. So I combined the learning and expertise of the two to take forward my career, and never stopped doing research, as well as treating patients based on the outcomes of that research.
That's wonderful to hear your pedigree. I did not make that connection between you and Bill McKenna. Bill McKenna, of course, was one of the key authors on the original arrhythmogenic cardiomyopathy task force criteria, and so many other major contributions to the field. So it's no wonder that you are in great company and doing great things. We're going to talk today about Brugada syndrome, and I'm often in the clinic. I tell the trainees I say Brugada syndrome of the SADS conditions, I find it the most challenging to understand. Um, we've had funny editorials like, "Does anyone not have Brugada syndrome?" It's a really tricky diagnosis. So maybe just take us back to the very basics, because even the basics are in flux, it feels. So from your perspective, what is Brugada syndrome?
Okay. Well, I think the way to understand it is that Brugada syndrome arose as a recognition of a specific type of ECG, or EKG appearance. And this is an ECG appearance called the type 1 Brugada ECG pattern. A particular shape to the ECG, a bit like an odd-shaped or triangle, superimposed on top of a normal ECG. And that was seen in people who'd suffered from unexpected and otherwise unexplained cardiac arrest as their only abnormality on their ECG, and without necessarily seeing any evidence of any other heart disease on all their other testing at the time. And the ECG, if most of your viewers will be aware of, is made up of a number of different leads. They're electrodes, they're electrical sensors that are placed across the chest and on the arms and the legs, or the abdomen in some cases. But the ones that we're interested in are the ones right at the front of the chest. And in fact, if we position them up and down the front of the chest, we get to see more of the Brugada ECG pattern in people who carry the condition. And these are called the right precordial, or the right ventricular, or the anterior chest leads. They basically reflect the right ventricular outflow tract, which is a bit of the heart where blood received from the rest of the body gets pumped out to the lungs. So it's a specific part of the heart, and it's slightly different from the rest of the heart for various reasons, including the development in the womb. It has some slightly different properties. It's a very thin structure, and I think it also shows evidence, even in normal people, in quotes, normal healthy people, of some slower conduction of electrical impulse in that region compared to other parts of the heart. And it seems to be a particularly prone area for rhythm abnormalities, whether they're benign or whether they could be more life-threatening. And in fact, you mentioned ARVC. It's one of the principal areas where ARVC can develop in its early phase. That's the arrhythmogenic cardiomyopathy. But when this ECG pattern was first recognized and described as in a series of patients, as you mentioned earlier on, it was described in patients who had suffered unexpected cardiac arrest, several of them who were children, and only had this ECG pattern to find. And this was described by the Brugada brothers. Just prior to that, in fact, a few years prior to that, an Italian group had described a similar group of patients, more adults though, some of whom had also had this ECG pattern, but had a mixture of ECG patterns that were abnormal for that bit of the heart, that right side of the heart. But there were definitely some there that one would have described as a Brugada ECG pattern, but they didn't describe it as a specific entity. They just described abnormal ECG patterns affecting the right side of the heart in individuals who appear to have otherwise normal hearts. What they did was they also took some little samples called biopsies from the heart and found that in that area, some individuals had evidence of very subtle but clear scar. That's abnormality, damage to the heart muscle that's occurred over time, most likely. That is an abnormality, but wasn't picked up by their normal tests. And as we've evolved our understanding of Brugada syndrome, it seems that the majority, if not all, patients who have this ECG pattern, where we've excluded all other forms of heart disease, they may also have this evidence of subtle scarring affecting the right heart, and most of it just not really visible when we do things like echocardiograms, ultrasound scans of the heart, or magnetic resonance imaging scans, cardiac MRIs. There are very subtle changes sometimes seen, but most of the time they look very normal. They don't look like they have any underlying heart muscle disease or cardiomyopathy. But if you actually get down to look at the heart under the microscope with biopsies, or even showing cases where sadly people have died suddenly, but we know they've died from Brugada syndrome, but their hearts have been donated for research, we've been able to establish that these individuals have signs of increased fibrous tissue, fibrosis. This is the term we use for evidence of scarring in the heart, but in a subtle way that is unlikely to ever show up on standard imaging that we do these days. So the initial thoughts that this is all just an ECG problem, an electrical problem in the heart, has now moved on to, well, this is probably actually a subtle form of heart muscle disease or cardiomyopathy that still just shows itself mainly electrically in terms of an abnormality of the ECG and mainly rhythm problems, rather than developing any signs of heart muscle disease or heart failure that can sometimes be associated with heart muscle disease. So that's sort of the background as to what we think is the underlying cause of the Brugada ECG pattern and Brugada syndrome itself. As to what causes that fibrosis, well, that's something that we're researching at the moment. And a lot of research is going in that direction to try and understand the mechanisms of it.
Well, you covered a lot of really important information there, and a very nice evolution and dipping a toe into the structural, which we're going to come back to. And our audience is a very astute, educated group, and they're probably thinking, as am I. So I hear right ventricular outflow tract, scarring, fibrosis. This sounds a lot like arrhythmogenic cardiomyopathy that we talked about last month. But to my knowledge, we have not seen Brugada syndrome affect the left side of the heart. We've only seen it on the right side in this very sort of localized area. Is that correct?
Well, in terms of the ECG findings, the Brugada ECG pattern predominantly is seen in those right ventricular leads, these ones right at the front. It's interesting, though, now that you mentioned the left side, because our research has also shown in two ways that the left side of the heart may also be affected, but again, very subtly. By doing these studies in the hearts of people who've died suddenly and whose hearts have been donated for research, and whom we have either a diagnosis of Brugada syndrome or other family members have been diagnosed with Brugada syndrome subsequently, we've been able to show that not only is there more fibrous tissue in the right side of the heart, but there is also in the left side of the heart as well. Again, it's not readily picked up at all, although in our patients who've undergone MRI scans of Brugada syndrome, we do see a small proportion where the MRI scan shows some evidence of scar in the left side of the heart, but not in the right side of the heart, because the MRI scan struggles to really show that sort of subtle change in the right side of the heart. But we do sometimes see that in the patient with in the left ventricle as well, the main left pumping chamber. Now we think that is we think that's due to the generalized process that's going on in the heart that predisposes towards this increased fibrous tissue. The thing that makes up fibrous tissue is called collagen. It's the scaffolding that supports the heart muscle cells that combine, that pump together to cause the heart contraction. And that scaffolding then is very important to the structure of the heart. And we think there's just more collagen interrupting the muscle fibers or in these individuals in a very fine and what we call diffuse fibrosis, very subtle process that's going on. And you mentioned that potential suggestion of overlap with arrhythmogenic cardiomyopathy. Well, there are some patients with arrhythmogenic cardiomyopathy who show the Brugada sign on their ECG. And there are, as I said, some patients with Brugada syndrome with their Brugada ECG pattern show some abnormalities in their MRI scan that you may think are more suited to arrhythmogenic cardiomyopathy. And when we do genetic testing, there may be an overlap in those cases with some cases of arrhythmogenic cardiomyopathy patients with arrhythmogenic cardiomyopathy gene abnormalities showing more Brugada appearance when they first present. So this is an interesting overlap between the two, but I would say the majority of Brugada cases by far will not show that degree of overlap. It's only a small proportion that may show that.
Right. And before we go into genetics, I want us to go back to one very interesting story, because of course, even before the Brugada paper, there was a concern in Southeast Asia of these young males. And so many of our families that in Vancouver, for example, we have a very high percentage of our population are from Southeast Asia. And they're very familiar with the phenomenon of Brugada in their culture. And so just to tell our viewers a little bit about this connection to the sudden death in young Asian males that was happening in the 80s. I won't make you pronounce all the cultural names that they have in their individual dialects, but we might have a go at it later.
Yeah, well, I think that the different terminologies. I think it's Abangunggut in Philippines, Lai Thai in Thailand and Laos. It's
Pokuri, yeah, Pokuri.
Yeah, so it's the phenomenon of young male sudden death in sleep, and it's sometimes even described as suddenly waking up and dying in sleep. And the phenomenon, I think, was noticed particularly amongst immigrants from Southeast Asia in the US, so a much higher frequency of these events occurring. And some of our colleagues that we know well, such as Professor Nadamani, started to research this more closely, and it became known as sudden unexpected nocturnal death syndrome, SUNS or SUNS. Eventually the connection was made when family assessment was undertaken in relatives of these young men who died suddenly, and there was a high preponderance of the Brugada ECG pattern. And indeed, such a high preponderance that it became quite evident that the frequency of Brugada syndrome was dramatically higher in Southeast Asia than it was in Europe or North America amongst white Europeans, white European origin individuals. So we may say that the prevalence of Brugada syndrome in Northwest European origin populations may be around 1 in 2,000 to 1 in 5,000. In certain parts of Northwest Thailand and Laos, we're talking prevalence is around 1 in 100 young men showing a Brugada ECG pattern, to the point where young male sudden death of this type is only second to road traffic accidents, the cause of mortality amongst young Southeast Asian males in these particular areas. And there's some really interesting genetic work that's just been coming out around this that is starting to explain this preponderance. Yeah.
So let's jump in, because the genetics of Brugada syndrome has been challenging to follow in some aspects, because early, I mean, a condition that affects mostly males and seems to be really prevalent in families. One would think this should be easy to find. Maybe it's even in something X-linked, where the female might carry it, but only the males are affected. But right now, the genetics, there's been so many genes found, but only a few are really associated with actual Brugada syndrome. So when you do genetic testing for Brugada syndrome, are you doing a lot of genes? Are you just doing sodium channel? What's your practice?
So you're right. I mean, over 20 genes have been associated with Brugada syndrome in the research, but if you really drill down into the robustness of that research, only one gene really stands out as being sufficiently strong in its association and potential for causation of Brugada syndrome. So you can see I'm being a little bit cautious about how I use my terms. That one can use it in straightforward genetic testing, clinical genetic testing. And that's, as you said, the sodium channel gene, SCN5A. And even then, it's only present in about 1 in 5, on average, individuals who present with Brugada syndrome as the first member in the family. They're called the probands. So the first people in the family develops the condition. That's in Northwestern European populations. Interestingly enough, in the Southeast Asian populations, it's between 6 to 9%. So they've got an even lower prevalence of these particular genetic variants in the sodium channel gene. And just to clarify what I mean by genetic variants, in this case, what we're talking about are what we would call rare or ultra rare, meaning that they're not present in the general population. If they are only seen amongst 1 in hundreds of thousands of individuals, and so they're very likely, because of their rarity, to be to have an implication for Brugada syndrome, and also have potential properties that are associated with causation in Brugada syndrome. This is called loss of function, meaning that the sodium channel doesn't work as well as it should do in these individuals, and causes abnormalities in the electrical impulse in the heart, slowing the conduction of electrical impulse in the heart, which seems to interact with the underlying subtle and diffuse fibrosis in the heart that I mentioned before, to cause further conduction slowing in the heart, predisposing towards developing this Brugada ECG pattern.
And the audience will recognize that we've talked about sodium channel in long QT syndrome, and of course long QT type 3, which is the least common form of long QT, but also the events are not as typical. They're not always exercise related. So there's definitely some relationship between long QT3 and Brugada syndrome, especially in those genetically positive ones. I'm curious because the sodium channel should be expressed everywhere, and you had everywhere in the heart rather, and you had put forward this very elegant paper, really saying, is there a problem with how the heart is excited or how it relaxes? So a depolarization versus repolarization. And I won't put you on the spot and make you choose which side it is, but that's the complexity.
It's depolarization.
It's clear. All right, fantastic.
I think there are secondary effects in the electricity of the heart, so that when the heart depolarizes, and obviously for the viewers, this is for when the heart activates itself electrically, that conduction of electrical impulse is slower than it should be, and that creates some spreading out of the impulse in the heart into a broadened wave of electrical impulse inside the heart, rather than a more narrow and more organized wave of electrical impulse, which predisposes towards the risk of arrhythmia. But it can also then cause secondary problems when the heart then recharges itself for every heartbeat. That's the repolarization that she was mentioning. That will also then be disturbed in some ways as well. So I think the depolarization also causes secondary repolarization effects that may also be relevant to the risk of arrhythmia. And the arrhythmia that we expect as causing Brugada syndrome is one of re-entry, which means that there's an electrical circuit being formed in this area of the right ventricular outflow tract, caused by this disruption in the wave of electrical activity being becoming less organized and less uniform in the way it behaves.
I think Brugada syndrome's been a real evolution even during the time you and I have been in practice. When I was in training, the diagnosis almost meant an automatic defibrillator implant. Where are we at today? Is Brugada syndrome as dangerous as we originally thought? Well, I think I've answered that. No, but how dangerous is it? How do we sort out who is a risky case of it and who is a we can wait and see case?
So it really depends on how the person's been diagnosed. So if somebody's survived a cardiac arrest, clearly they've declared to themselves and to their doctor that they already have very high risk. And undeniably, those individuals need to be treated aggressively, and aggressively meaning having an ICD implant. I'll talk about other potential treatments afterwards. So, but I think that's that's where we stand at the moment in terms of what all the international guidelines say. In terms of other people who haven't had a cardiac arrest, there are two major factors that seem to be well represented in all the studies as being indicators of higher risk. One is if you actually can see the type 1 pattern spontaneously on the ECG. I'm going to explain what that means in a moment. And the other is as if somebody has suffered an unexplained blackout. That is likely to be from a heart dysrhythmia, an arrhythmic abnormality in the heart. And that's called arrhythmic syncope. Now, there are two challenges there. I'll first of all deal with the syncope bit. Is most patients with Brugada syndrome don't suffer syncope. And most patients who present with cardiac arrest or with a sudden death may not have had a syncope beforehand. So syncope is not a uniform warning sign for most Brugada patients. In terms of the type 1 pattern, that is that being present on the ECG when people are first diagnosed indicates a higher risk to begin with. But on its own, it doesn't have sufficiently high risk to say, oh, you must have an ICD because your risk is that high. It's actually not the case. Most of our patients with type 1 patterns can just be looked after and monitored to see if there's any potential for increased risk. The only concern we have clearly is that if a blackout is a syncopal episode, is all we're relying upon for detecting the risk of sudden death or cardiac arrest, then we're going to really struggle to prevent sudden deaths from occurring. So there are different approaches to trying to determine the risk. We call it stratification of risk. So there are going to be some patients who will have additional ECG changes with their type 1 pattern that in combination is likely to cause or be associated with higher risk. And there are some of the community who also support the use in patients who have this spontaneous type 1 pattern of something called EP studies, programmed electrical stimulation, that may help in some cases to differentiate degree of risk. It's a challenging area because there's a lot of disagreement around the use of EP studies, programmed electrical stimulation in Brugada patients. And I use it personally, but only reserve it for these patients who have the spontaneously appearing type 1 pattern on their ECG, and in whom I've had a very detailed discussion about what the risks and benefits of doing an EP study is. The end object of the EP study may be to determine whether there is a slightly higher risk. So I'm going to explain that in terms of percentages of risk per annum. And this is quite not always straightforward to understand. So we all have a small percentage chance per annum of dying from any cause. So in the UK, if one's a young male in late 30s, early 40s, the risk is around 1 in 1,000 to 1 in 500 of mortality per annum. If you have the Brugada syndrome with a spontaneous pattern, that is closer to just under 1 in 100, so 0.9% or 0.8% in some of the larger studies per annum risk. And with the EP studies, if one provokes a rhythm abnormality during the EP studies, then there is going to be a slightly higher risk, increases to about 1.7% per annum, according to a large meta-analysis where one adds all the factors, risk factors, all the studies together to look at potential risk factors. Now, unfortunately, that isn't a very good positive predictive value, meaning that it's not really good at picking out people at high risk, but it does suggest that there's a slightly higher risk. And for those who are negative, there's a slightly lower risk. And in the most recent data from Italy, for patients who are very well treated and know to avoid all their various risks, is actually coming out at lower risks with the electrical studies. It's now starting to suggest that maybe those electrical studies only suggest a risk of 0.7% per annum. And so it's a moving field at the moment as to how useful the EP studies are, but I just discuss them very carefully with patients and to see whether it's something that would appeal to them. When I say appeal to a patient, first of all, what is the end objective? Well, the end objective is to decide whether one thinks an ICD may be appropriate or not. First of all, does a patient want to consider an ICD? The invasiveness of it, the potential long-term complications and risks of an ICD is not negligible, particularly in younger males who are the group most likely to be at risk. And so one has to have a very careful consideration with about whether that is even worth considering. So if somebody doesn't want to have an ICD, there's no point trying to risk stratify further. What one needs to just take forward very careful monitoring for risk over time. If somebody with the levels of risk I've described is too anxious to think about taking forward life with that level of risk, and for some people that is too much, that it doesn't matter to them whether they would have some additional risk based on an EP study, they would still be concerned about the risk. Then we have to take forward a discussion about treatment on that basis. So it's only for those people in the middle where knowing a little bit more about their risk may influence their decision about whether they want to consider an ICD or not. And so it becomes quite a long discussion about the risks and benefits of ICD and the risks and benefits of using an imperfect tool for risk stratification that's never going to give you 100% accuracy.
Very complicated discussions, and I appreciate the rigor of your data. You've done so much work in the field, so it's nice for our audience and for me to have some of these numbers. I think that a very important message is that in general, especially these family members that are picked up by what we know is cascade screening. So your relative may have had a very significant case of Brugada syndrome, but you as a relative may be removed. You're at a much lower risk of having an event, and so we don't automatically default to an ICD in anyone who may have a relative with Brugada. And so
definitely not. I think surely the over-treatment of Brugada patients is a real concern for me, because I think there is only a very discrete group that have higher risk. And just what I wanted to get back to as well is just to clarify that a lot of our patients, particularly in Europe, are diagnosed using something called a sodium channel blocker. which is a medication that can bring out the Brugada ECG pattern on the ECG when given as a diagnostic test in people who have a family history of Brugada syndrome. And we have a particularly potent one called ajmaline in Europe, while in the US and in Canada, procainamide is the one that's used much more commonly. And if you have an ajmaline or procainamide-induced ECG, while there is an increase in risk, it's only a very slight increase in risk. And even that Italian data and our own data that we've been looking at suggests that the risk there is starting to drop to 1 in many hundreds per annum risk of something happening, much closer to what you'd expect for your own, for one's own risk anyway, just from any cause. So we really never treat patients who've not had a symptom and in whom a sodium channel blocker has diagnosed the type 1 pattern. We monitor to see if there's a development of the type 1 pattern and a development of risk over time. In our experience, that's about 1 in 10 individuals in families may eventually show that pattern. So it's worth monitoring, but it still means that 90% of those relatives are not going to be affected in any severe way.
Yeah, that's very reassuring. I'm right now a bit on the fence about the role of the sodium channel test, especially in a child whose parent, may have genetically elusive Brugada syndrome. So we don't know a genetic marker, and then do we test them with a procainamide? Do we give them a medication that might unmask this or not? It's not, again, it's another one of these very detailed discussions about, why are we doing the test and what are we going to do with the information? I want to just in our few minutes, I want to ask about fever. One of our audience had keenly talked about COVID and being receiving sort of antivirals. I don't want to focus on COVID because I think there's a lot of people just having regular the common cold and other things that also get fevers. You have let's take a family member whose relative has had Brugada in a very in a clear way. What are you advising about fever? Are you telling them to get an ECG during a fever or just to treat fevers? Are you making any special recommendations around fevers?
So we ask them to treat fever, but if the fever is persistent, and I can't tell you the Fahrenheit levels, but anyway, then we ask them to go to their emergency department to have an ECG done, and an ECG done with the ECG leads placed in the standard position, but also up the breastbone here, called the high precordial ECG leads, to see if the type 1 pattern is developed under the effect of fever. And if it has, then we recommend that they're observed until the fever settles and the type 1 pattern dissipates, because that could be a period of increased risk. And that's what I mentioned about well-treated patients whose periods of risk are being treated more aggressively with fever-lowering medications such as acetaminophen or ibuprofen, and get monitoring in the emergency department if that does happen to them. I mean, there are other circumstances where one may also consider avoidance of risk. There are medications that can be given that also block this important sodium channel in the heart, much like the procainamide or the ajmaline medication does to make the diagnosis. They can bring out the type 1 pattern, and we recommend that that patients avoid these so they don't temporarily increase their risk while they're on the medication, for example. So there are a few other things that can be done to remove risk even further for these patients.
Yeah, absolutely. I'm just noticing that we're at time here. It has been an incredible discussion, and I still have a list of questions that I'm sure our audience also has. So we might have to have you back for a sequel, Brugada Part 2, not a Type 2. But I've really enjoyed learning from you, and the work you're doing especially in this space is incredible. I remember so many of your important papers have made the rounds and given us all pause. So thank you so much for joining, and and keep educating us with the amazing work you're doing in this space. And I thank you.
Thanks so much, Stu. It's been a real pleasure.
Well, as promised, I learned as much as anyone. I think Brugada syndrome is, as you could tell from Dr. Behr's conversation, it's a complex, it's a nuanced condition. And my advice to those of you who are potentially impacted, make sure you're dealing with the experts. So in Canada, we're fortunate we have a good network of genetic cardiologists who spend their time in this space. The genetic testing really needs to be informed by genetic counseling. We get some referrals about genes that may not be really strong enough to follow in families. So lots and lots of learning, and with that, I think we're at time. I've really enjoyed my conversation with Dr. Behr. I'm looking forward to our next session. As I say, the guests are always teaching me a lot, and I hope you're enjoying them as well. If you have time to make a donation to support what we're doing here at the Canadian SADS Foundation, we have a lot of operating costs, including putting on this webcast and just keeping the website going. So any amount is appreciated, and we will see you next time.